Very much for the invitation. Hopefully the slides are going to appear. No? Maybe not.
I just don't sabotage.
Yeah, it's nothing unusual for an obstetrician to be sat waiting for 20 or 30 minutes while prattles around for a while. So I'm not at all uncomfortable with this. I was told I was going to go first. I thought for the first time I get to go before an anaesthetist. You know. It would be wonderful as a surgeon if I could do my operation and then leave you to do the anaesthetic afterwards.
You do.
So slightly grand interpretation. In fact, when I was first asked to talk, I was asked to talk about the maternal death inquiry because I'm the obstetric lead for that. But then when the programme came, it had a different title, so I thought, oh well, I'll talk about medical legal issues as that's what I've been asked to talk about. Okay. So I'm going to cover some things which are relevant to everybody, a bit perhaps less relevant to anaesthetists than some of the later stuff. So I'm going to talk about the new law on consent. Just a quick show of hands. Who's heard of Montgomery? Okay, so about a third of you. Okay. Yeah, I'm speaking at an obstetric meeting later in the week. It'd be interesting to see if there are any more well informed about it. I'm going to talk a bit about timings for birth, and I'm going to talk a bit about damage and stuff. So this is completely cribbed from the MPS. It's about a case in Montgomery, lady in Montgomery, who gave birth in 1999. Now that's important because this case completely changes the rule of consent, but importantly it changes the rule of consent going back to at least 1999. So you've all been doing it wrong for the last 20 years, and you have. You'll find that when you hear what we have to do now. So this was a young woman who had diabetes. She was thought to have a biggish baby. She was about 4'10", and the agreement between the experts was that the risk of the baby getting shoulder dystocia was about 9 to 10%. The doctor who was looking after her didn't think that they should tell her that because she'd probably want a section. And you don't really want to do sections on everybody, so you don't tell her that might be the risk. The baby, she had a vaginal birth, she got shoulder dystocia, the baby got brain damage. Mrs. Montgomery thought that was probably a bit unreasonable, and so she sued the Lanarkshire Health Board, and it went all the way to the Supreme Court in Scotland. And her case was that she should have been offered caesarean section. The initial defence was doctors didn't offer caesarean section, Bolam. It was logical not to offer caesarean section because people might want them and they weren't really necessary for life. And the first two courts in Scotland agreed with the claim, with the defendants, and through the courts the case out. And in the end it went to the Supreme Court, who didn't agree with the defendants, and so produced a judgment which found for the family and have effectively rewritten the law of consent. And the conclusion of that is that the Bolam test no longer applies to the issue of consent. No longer is it that you have to tell somebody what you think a reasonable doctor, one of your reasonable colleagues would tell them about the risk of any procedure or a healthcare event they're going through. It's deemed unsuitable as a method for assessing risks because basically doctors can all be a bit woolly about it, or healthcare professionals can be. So we now have to tell women or patients what they think they should need to know. So the court found for Mrs. Montgomery that she should have been informed of the risk of shoulder dystocia, and also had to find that if she had, she would have had caesarean section, and that cost the health board £5.25 million. You can probably add 3 noughts to what it's going to cost the NHS in the next 10 years in judgments. We've moved therefore away in consent terms from the test of the reasonable doctor to the test of the reasonable patient. Now, if you think trying to work out what a reasonable doctor is, try and work out what a reasonable patient is. You know, and that, as an expert, is what you're asked to do, and then in the end, it's what the courts will be asked to do. And most of the people who sit on the big high chairs in the courts would be about as far away from what you and I would think was a reasonable patient as the moon is from here. So it's going to be quite challenging because they see risk in everything in court. So there's a strong likelihood that if something bad happens and you haven't told somebody and they make a claim, they're going to succeed. Which is why I think we can add 3 noughts to the 5 million that it's cost overall in this case. So the test of materiality is whether in the circumstances of the particular case a reasonable person in the patient's position would be likely to attach significance to the risk, or the doctor is or should reasonably be aware that the particular patient would be likely to attach significance to it. So in elective surgery and elective anaesthesia, if I'm honest, I don't think it really is going to make a great deal of difference, because there's been a GMC obligation to tell people about the risks of procedures and what they might reasonably expect. And you've got time to do it generally in an outpatient clinic or before you do an operation. So those issues are a bit less challenging. If I'm going to do a hysterectomy on somebody, I've told them for years that they're going to die, mostly because I know how I operate. You know, we've always, for elective cases, been reasonably clear with women. So the problem is going to be the non-elective cases or maternity, as I'll come on to. And the other thing is, everybody's in the past talked about this 1% rule. It's never really been a rule, but it's very definitely not a rule now. So don't think that just because something happens less than 1% of the time, you don't have to tell people. But you do now have to tell everybody, for elective procedures, any significant risk. And believe me, whatever procedure you do to somebody, they can die from it. So I think death has to be included in the list of every procedure that you do. Now, obstetrics and maternity care, my field of work, is much more challenging, because the problem is that we think it's normal. And Jackie's going to talk to you about better births, and I'm sure she's going to emphasise normality and tell you all how actually we should be leaving women alone to get on with the beautiful opening of the flower and the birth of the baby, and it will all be truly wonderful. And it, you know, of course it is. You know, I'm into immediate gratification. There's nothing much better than pulling out a pink screaming baby. It's a fantastic experience to be involved in. But the problem is that it can go wrong. And currently the professional view, the NHS, the RCOG view, is that women should not have elective section just because they fancy it. But there's a bit of a dichotomy of the public view. There's the NCT, who would strongly endorse that RCOG and DOH view that normal birth was a good thing and we should be discouraging intervention, and I think the RCM would find themselves in support of that. But we have the other group, the TPTP group, to Posh to Bush, who perhaps feel the other way. And we're now struggling with the fact that there will be more and more women who will be able to say that, in their view, the risk of a normal birth is such that they don't want to go through that procedure. And even if you try to persuade them that the risk of a caesarean section is greater than a normal birth, it's not your choice anymore. It always fascinated me that when the choice agenda came in, everybody said it was women's choice about what they should have. But then it actually came out it was their choice, but as long as they didn't choose a section. So they were allowed to choose normality and everything that worked in it. But now this means that somebody can choose a section. But it also raises other questions about, do we have to tell every woman about all the risks of childbirth? I don't know a single obstetrician or midwife who tells a woman that she's got a 3% chance of having her anal sphincter damaged at the time of a normal birth with her first baby. If we did, how many do you think would have normal births? We don't. So I now think that every woman out there who's had a third-degree tear could sue me and win, because I think that's what Montgomery says. So we're going to be in a bit of difficulty, I think, with this judgment, the way it's going to be interpreted. But even more difficult, what do I do with the woman who turns up in my clinic at 34 weeks and says, I'm fed up, doctor, I want my baby out today? Because it's her choice, it's not mine. And I can tell her it's risky for a baby, and I can tell her it's more risky that she should have a problem, that she could have a problem with the baby being born early. And I'm probably going to say no, because it's particularly stupid to want that being done, and 99 times out of 100 I'll get away with it. But the one time that that woman comes back the following week with a stillbirth, then she would succeed in a claim against me. So it's quite a challenging horizon that we're faced with in consent terms. Okay, so having completely depressed you, because it's been depressing me since the judgment came out, I like to share my malcontent. I'm going to ask you a few questions. I assume most people in the audience are anaesthetists. I know there are some obstetricians and maybe some midwives and things, so I'm going to pretend you're all anaesthetists. Sorry to the obstetricians and midwives, but no. Here's some questions. You're involved in this case. So trial of forceps in theatre. There are fetal heart rate decelerations, so everybody's a bit anxious, want to get on with this, and you've tested your block and you think it's sufficient for me to do a forceps, and it's rising, but you know it's not quite ready for me to do a section. But I'm saying, I've got the drapes on, can I go? Can I go? So what's the answer? Those of you who think the answer is yes, the heart rate's about 60 at this moment, maybe recovering a little bit. Who says yes? Who says I can go? I can go, I can start my forceps. Who says I can start my forceps? Start the forceps. Okay? Vast majority of you think I can start my forceps. Who says no? I'm presuming the rest of you, unless some of you are asleep, which is probably fair enough. Okay, I'm going to come back to it. So my second question to you to think about is, the decision's been made, 12:15 to following 12:51, following an abnormal fetal blood sample, that this baby needs delivery by a caesarean section. The team gets her into theatre. The baby is born at 13:19, within 30 minutes of the decision. Everybody's happy that there was no reason to deliver before the fetal blood sample, but the fetal blood sample was the trigger that led to it. The baby's born in poor condition, and the claimant says it took you too long to deliver that baby by caesarean section. Will they succeed? Who thinks they've got no chance of succeeding? 28 minutes? Who thinks it's very unlikely they'll succeed? And who thinks they'll probably succeed? Yeah, only because he's bloody advising.
Sometimes it says that.
Okay, so third question. When we're performing an urgent caesarean section for concern about fetal well-being, an abnormal fetal heart rate pattern, so it's not a bradycardia, but the CTG is awful, and we want to do a caesarean section, who decides whether it's a general anaesthetic or a spinal anaesthetic?
Can we have a third option? Yeah. The patient.
Okay. Well, so the patient is you can have another option because in the end, clearly, it is the patient. But but the patient is happy to take the advice of their professional colleagues. Okay. So who thinks it's all right for me as an obstetrician to tell you to do a GA, or who thinks it's the anaesthetist's job to decide on the mode of anaesthesia? So who thinks it's the obstetrician? Who thinks it's the anaesthetist side? Yeah, okay. Yeah, I know. That's what David always comes out with as well. It's all bollocks.
See, multidisciplinary.
Well, sorry, Debbie. I've seen one of my colleagues. If I went into theatre and said we're doing a fetal section for fetal distress for deceleration, but I want you to give her a GA, Debbie would look at me very politely, turn around, completely ignore me, and do exactly what she wanted. And she'd be absolutely right to do so. So I'm going to come back to those because they're kind of it needs this building. Babies get damaged in labour as a result of three predominant patterns of injury. One is trauma, and one of our big difficulties is the court believes caesarean section is entirely safe, and yet I see a case every month in my medical legal practice where somebody has fractured a skull or damaged a baby's brain trying to get it out of caesarean section. So it isn't, but that's not what the courts believe. The courts work on things are either right or wrong, but they don't use kind of sense to decide that. They use a 51% rule. So if something happens 51% of the time, it's always true. If it happens 49% of the time, it's always false. And therefore, as caesarean section leads to a good outcome in more than 51% of the time, caesarean section never has any problems. That is the legal position. It's pointless, but that's the world they live in. So the other cause of babies getting brain damaged is acute brain injury. And that's either it's usually because the baby has a fetal bradycardia, and it's because either the mother collapses, or the placenta separates, or the uterus ruptures, or the cord gets tangled somewhere, or very occasionally the baby is chronically hypoxic and then collapses. That leads to a fetal bradycardia, damage in 10 minutes, death in 25. Damage in 10 minutes, death in 25. That's quite important, because not everybody knows that, but actually the lawyers think everybody does know that, and thinks everybody should respond in that way. Chronic problems like placenta incitation, and this is what CTGs are aimed at. They're much less common now than they were when I started doing this 20 years ago, but they're the ones we've got a chance of avoiding. The acute ones I think we struggle with. And this is what it leads to in the baby. So this is an acute brain injury which is damage to the thalamus, deep grey areas of the brain, leads firstly to motor disability, and then with a more prolonged hypoxia, the baby starts to get learning difficulties as well. Whereas the chronic damage is in the watershed. This is so-called eulogyaria, looks like mushrooms in the outer areas of the brain. Nobody really knows how long this takes. All the medical legal experts say it takes at least an hour, but it is really how long is a piece of string, and so we don't know how long it is necessary for a baby to have hypoxia to get this, but we think it's at least an hour. So acute profound hypoxia is bradycardia around 60 to 70, damages after 10, dead after 25. Real problems in medical legal world now because paediatricians are cooling babies after birth, and that's completely messing up everybody's timings, so it's going to make it much more difficult to understand what that means. And cases are argued over a single minute. A single minute, and I'm going to show you what they mean. So in clinical practice, this is really uncommon. In my clinical practice, my labour ward has 6,000 births a year. We might see it every couple of years that we get a bradycardia that leads to damage. In my medical legal practice, probably half of the brain damage cases I deal with are due to acute profound hypoxia, due to a bradycardia. And actually that's probably going up as a proportion rather than down. So for me that's kind of 100 cases a year. So we've got a potential damaging event. So what type of anaesthesia are we going to be giving? Well, this is the argument. It's general anaesthesia is quicker than regional. And what a claimant will always say is that even though most of you would give a regional anaesthetic for concern about fetal compromise, even though often the fetal heart rate's not actually too bad until you get into theatre and then suddenly it collapses whilst you're in the midst of it, they will always say that if you'd given a general anaesthetic, that would have been a bit quicker. That saves them a few minutes, and that's what gets them home on their damage. So it can be very important. The clinical reality is, I don't tell anaesthetists what type of anaesthetic to give any more than I expect them to tell me what type of operation to do. But we do get into these situations in cases where somebody will say that the obstetrician thinks it should have been a GA, and then the anaesthetist, the anaesthetic expert, not wanting to be against the claimant's own case, will kind of say, well, I would defer to the obstetrician. It's bollocks. They wouldn't. Not in reality. They do it there because they don't want to disagree with the case that's been put. So the medical legal view is that there's always should be a discussion, and that somehow this discussion would always lead to the view that the claimant wants it to lead to. The problem is the discussion would take longer than getting on with the bloody procedure. So why don't we just get on with it? So trial of forceps, going back to one of my questions, trial of forceps is performed in theatre because it's a higher than average risk procedure. That's why we do it. It can fail. But particularly if you're going to do a rotational forceps, which really you should only be going to theatre if you're going to do a rotation, causes a risk of acute change in the fetal heart rate. So I think most of you said that they thought it would be a reasonable thing for an anaesthetist to tell you to get on with it because it was all right for the forceps but not quite ready for the section. The obstetrician was told in this case that they could, maybe was in theatre, said get on with your procedure, started to do the rotation. The rotation caused an acute fetal bradycardia. Took slightly more than 10 minutes for the baby to be born. Baby's got damage due to an acute profound hypoxic insult. if they hadn't started the procedure till the anaesthetic was ready for a caesarean section, then the baby would have been born in less than 10 minutes. The baby would not have been damaged, and that would have saved the NHS somewhere between £5 and £7 million. Well, that's always the benefit of hindsight, but the reality is, even if you're trying to give a GA from scratch, your GA might take 6 or 7 minutes, but I've then got to do my operation and get the baby out. So 10 minutes isn't quite long enough unless you're ready. Another case, not quite the same, but fairly similar, where they started the procedure, got a bradycardia during the procedure. In fact, the anaesthetist had been absolutely clear that they weren't to start before the anaesthetic was ready for a section. But in this particular hospital, they didn't open the theatre trays for a trial. And when we were sat in conference with the clinicians from the hospital, they said, well, I think it's not very big, so we've not really got an awful lot of room. And actually, we do so many trials, we'd waste a whole load of kit if we opened the kit every time we did a trial. So we only open it once we make the decision. Because there was a delay in opening the kit, it took 12 minutes to deliver the baby, whereas if the kit was already open, it would have taken 8 or 9, and that's cost the NHS between £5 and £7 million. This one, for me, is almost the saddest of them all, because it literally did come to 1 minute. And this was a case where somebody decided to do a trial of operative vaginal birth. They did it appropriately with anaesthesia absolutely ready for caesarean section. They put the forceps on, they twisted the baby's head, the heart rate dropped. But the trouble is they decided to do it in the room next to theatre rather than in theatre because they didn't want to move her. So then they had to move her when the bradycardia happened, and it took them 11 minutes from the onset of the bradycardia to the baby being born. And if they'd been in theatre in the first place, it would have taken them 8 or 9 minutes. And you know the answer. It cost us an awful lot of money. So I absolutely understand the day-to-day pressures and imperatives of a nervous obstetrician's distress at the bottom of the table, asking you to allow them to get on with the procedure. But if it's not a bradycardia, then a few minutes is not going to make a difference. Once it's a bradycardia, 1 or 2 minutes makes a difference. So as long as the fetal heart rate's recovering, then wait 2 or 3 minutes to be ready, rather than going ahead with your procedure. Okay, so the other question I asked about was decision delivery interval. You felt reasonably confident if you get the baby out in 28 minutes, you'll be able to defend the case, and probably you will. But the problem is that it's certainly true that taking over 30 minutes is not a breach of duty. It's fascinating that some of the lawyers are absolutely obsessed by this idea that if you take more than 30 minutes, then you've taken too long and they will succeed in their case. But the literature actually shows we get about 60 to 70% of babies when there's concern about fetal well-being out in 30 minutes, and about 80 to 85% in 40 minutes. So certainly up to 40 minutes, you've got a reasonable argument about. But the problem is, the contrary is also the case, which is that achieving birth in 30 minutes doesn't necessarily mean that you have been acceptable. It's been acceptable practice. Now, the defence to a case taking too long is often the circumstances of the case. So it's amazing how frequently cases that end up in litigation happen at the same time as another case is in theatre. And again, the claimant lawyers are very unsympathetic to the fact that trying to do 2 things at once is not possible. I mean, it amuses me greatly that lawyers can criticise doctors for taking 4 minutes to do something, and they will spend 4 days in court debating whether it should have been 3 minutes or 4 minutes. There's an absolute lack of insight about the reality of how time passes, but they will. Often there's a need to get additional staff, getting an anaesthetist from somewhere else. So often an anaesthetist or an ODA, or actually sometimes a surgeon if the registrar's already in theatre. Delays in the woman agreeing. It's quite important to actually, when there's a more than what you might call usual discussion with a woman, be very clear about the time it took you to make the discussion with her. Because if she wants time to think about it, and you're then being criticised for the baby being born 3 minutes later than it should have been. That's got to be something that's worth putting in the melting pot. These cases go for between 5 and 7 million. They're negotiated about whether it's 50% responsibility, 60%, 70%, 80%, 90% responsibility. If you take 5% off your responsibility, you save the NHS £250,000. Something like a note which says the woman took longer than average to discuss might allow a good defendant barrister to get 10% discount. £500,000. It's quite worth it, isn't it, for a bit of a note? Now, you might say, well, that's awful because the parents and the family then get less money. But this whole thing's a game. This is not real world. This is all a game about money. And that's what it is all ever about. Okay, and then you can get difficulty with the elements of the process. Difficulty with the spinal. Interesting, David saying about multiple attempts. So, what's a multiple attempt with the spinal? Is it if you don't actually take the needle out of the skin but keep prodding like that? Is that still one attempt, or is it only when you take it out? As you say, the patient and your perspective might be different, but there is guidance that if this is a caesarean section for fetal compromise, you should not be having multiple attempts at spinal anaesthesia. So that's going to be quite important for you to think about. And then surgical problems on entry. Usually a section you can get the baby out in a couple of minutes once knife to skin, but sometimes it takes a lot longer. So those are all the things that we would argue about. The claimant will always suggest that this was actually a more urgent section. In my mind, and I'm very happy if we chat about it, a category 1 caesarean section is life-threatening to mother or baby. That's a fetal bradycardia. Category 2 is pretty much anything else where there's concern about fetal well-being. If you've got, I accept if you've done a fetal blood sample and the pH is 7, you're probably a bit uncomfortable at that point, so you really want that one doing quite quickly as well. But every section in litigation is category 1. Every baby that's come out damaged in the end, apparently that was a category 1 section because they look back on it. So be really clear about why you're doing sections and what your targets are, because they will pour over your guidelines and documentation. There's a hospital not actually too far from here who had a guideline which said they would achieve all category 1 sections in 20 minutes. And actually we got their audit out, they actually managed it in 15% of cases. But in the case in question, the claimant relied upon their standard as being what they were expected to achieve. Don't set yourself an unachievable goal, because you will fail, and that will help the claimant. Many of the cases, and the reason why 30 minutes is not a golden rule, is actually the biggest delay is often getting the woman to theatre. And I know I'm going to irritate the anaesthetist, but we shouldn't wait for you to come to the room to see the patient, I'm afraid. If there's concern about that baby, let's just get everybody where we need to do what we need to do to them. And then you can talk to them in there while things are going on. Because if I wait for you to come to the room, and then you piffle about in the room for a while, and then we've got to move, everybody's lost their momentum. Nobody gets it moving. So as Debbie will say, I'm very irritating if I say this lady needs a caesarean section and it's because I'm concerned about the baby's well-being. I start taking the monitor off and I take the brakes off the bed and we move. And David's shaking his head in horror at me. But that's the only way to get these procedures done in a timely way. Okay. So let's go back to our final question. Who does make the decision about GA? My view, and David can say if he agrees or disagrees, is that my role is to tell you the category. Category 1 is a bradycardia or an awful pH, and I think with those you're probably going to do a GA unless there's a real contraindication to a GA. And that's what I think my mind would be. Category 2, an abnormal CTG or an FBS, which is a bit borderline, then I think that that's going to be a spinal unless there's something that, from an anaesthetic point of view, means that that's wrong.
If you're preventing the anaesthetist from going to see the patient in the living room to work with the jaw, that working jaw can be topped up, less time it takes to transfer the patient, give them, pre-oxygenate them, and GA them.
I'm not expecting them to do a GA, and I wish that was true. I wish that was true. That's what anaesthetists say all the time. But actually, the patient's in the... If I push the brakes off the bed, and I push the patient in the anaesthetic room before the anaesthetist gets there anyway. And actually, that's usually where the anaesthetist is near theatre. So if I move the patient quickly, it gives us a better chance of getting the procedure done promptly. So it's great winding up anaesthetists. Okay, so that's my endpoint. That's what I think the anaesthetists do, and I'd be interested to see what David thinks the anaesthetist would do in that situation. Thank you very much. We're going to take questions now. Okay.
10 minutes for questions, everyone, please.
While you're getting it together, I'll tell you why Derek shouldn't push the patient around. And he shouldn't push the patient around because he is Derek Tufnell, right? And because his registrars, his SHOs will see him doing it, and they'll do the same thing. If Derek pushed the patient around and I was in theatre, I would know he was making the right decision, and I would leap on top of that patient and give whatever anaesthetic was necessary. But it's not the same, and it's that you've got an SHO at one end and an SHO at the other end, trying to replicate what their bosses do. So it works in his hands, and it works in my hands, and it works in the hands of my consultant obstetrician. It doesn't work in other people's hands.
Yeah, well, see, but that's then getting to the debate of who, has the decision been made? And once the decision's been made, you need to make all move to theatre. And if I was an anaesthetist, actually the thing that really irritates me is when the anaesthetist has put the spinal in and somebody has to go and find the surgeon. That must be even more irritating than me pushing the patient to theatre, because that's what really would irritate me. If it's an elective section, that's fine, because crack, I can have a 3-course meal by the time the spinal's going. but for an emergency section, the obstetrician should be with the woman, and part of my job is to move the woman to theatre.
Yay!
Probably be in his chambers.
Or the chamber 4.
Hi, thank you very much for jointly depressing the whole audience as well. It's always, when you come to these meetings, it ends in a depressing note, but, hey ho. I'm one of the consultant obstetricians, so I'm going to go with Derek in that, I've read papers as well where the consultant obstetrician takes the leadership in moving the patients to theatre, things get done quickly, and our juniors should learn from it that it is important on those very few occasions that the patients have got to be moved. You are there and moving the bed. And in fact, our audit had consistently proven that the delay has always been moving the patient from the room to theatre. So I completely concur with you, Derek, on that. But my question to you is, you've talked so much about the recent Montgomery case. My issue is there are some patients where you give all the advice based on the research evidence and everything, but they still go and they want to deliver the twins on a barge, and then the complications happen, and then they come back to you, and despite whatever you have written in the notes, there's always loopholes that the barrister finds that you have not said this, you have not done that, so the liability still lies with the obstetrician. The reason I'm asking is there is more and more women who do come having their own personal birth plan. So and you do want to support the women in having that experience, but where do you stand as a consultant obstetrician when you don't agree with a decision that a patient is making, but you have to go along with supporting what their birth plan is? And this is a consistent problem in our union.
Yeah. Well, as David said, the problem is David and I can give our views, but in the end our views might not be the same as the judge that you end up in front of in a particular case. So women are entitled to make choices. They're absolutely right to do so. Our obligation is to inform them of the risks and benefits of the choices that they're making. And if a woman chooses to have twins on a barge, then good luck to the midwives. That's my... I will have told her what I'm worried about, and I will have told her about the risk of death, and I will have told her about the risk of disability for a child, and I will have told her about her own risk of death and disability. And if she makes that choice, that is her choice. That, what really, as you say, then becomes a bit sickening is that when it does work out badly, they then come in and try and blame somebody else. But that's human nature, and you're never going to get away from that. If you practice your whole life trying to avoid that, you're going to run into problems. But just to give you one other thought example, I know it's not a case that's been written up, and actually people are not keen for it to be written up, but there was a case of twins where the woman said in the antenatal period she'd quite like a section. Interestingly, it was a clinic that was run by midwives, supported by consultants, so the person who counselled her was a midwife. And the midwife said to her, section's an option, but we don't recommend it. Nice guidances with twins, you go for a normal birth, that's what we'd suggest you should have. The woman said, oh, okay, and decided to have a section. decided to have a normal birth. Normal birth, one of the twins came out badly. Went to court because the family's account was, we demanded a caesarean section, we insisted we wanted a caesarean section, and the midwife wouldn't let us and wouldn't refer us to the consultant. The midwife's account was, I definitely gave them the option if they wanted to, but at the end of the consultation they were happy to have a normal birth. The judge found that the family had asked for a section, but had not insisted on it. Found that the midwife had talked to them about the options and had mentioned section. And therefore you'd find for the defendant. The judge found for the claimant because apparently the midwife should have known what the woman wanted, despite the fact that she said at the end of the consultation she actually was happy to go for a normal birth. So predicting what judges will do is almost impossible. The lawyers call it litigation risk. What they really mean is there's an idiot in the chair who's going to decide this.
I'm going to remember that he slagged off judges the next time we're in court opposing each other.
Good afternoon. My name is Amit from one of the researchers at Halifax. This question is for Mr. Tufnell. Mr. Tufnell, just imagine a situation where you have actually wheeled the patient into an anesthetic room or a theatre for a delivery that needs to be achieved very, very promptly. But it's the middle of the night and the anaesthetist has not met this patient before or knows nothing about her. How much time, in your opinion, is enough time or adequate time to safely assess whether to give a regional anaesthetic or a GA to this patient?
The same amount in the theatre as it was in the room, but the difference is that the patient, everything else can be going on around the patient whilst you're having your perfectly appropriate safe time to make that decision.
Everything else can and does indeed go around the patient, and that can be very distracting in that moment, in that time where you need to be making really quick decisions as to whether...
Well, that's the way of the world, I'm afraid. If we don't all have a quiet room in which to make every decision. If you're in the room with her, there still should be an awful lot going on around her. That's not going to help you. It's no excuse to say you need more time in the room. To be fair, the argument that was made about topping up the epidural, that to me is a reasonable argument. Sometimes if you've got a really good working epidural, if the anaesthetist is there and they whack an epidural and then it's ready when we get to theatre, that's brilliant. But actually the reality is that that doesn't happen very often. So moving people to theatre quickly is going to get you more prompt delivery.
Thank you.
The correct answer to your question in court from a consultant obstetrician expert would be, I'm completely unable to comment on that because that is a matter for a consultant anaesthetist.
Yeah, well, actually, you see, that's the problem. That's not the right answer, because as an expert, I am entitled to give opinion on matters which I think have expertise. And how long it takes, and I think it's I'm perfectly able to say that a medical assessment takes the same amount of time in room A as it does in room B.
But it's interesting to see even the two of you can't agree. Let's alone then.
Yeah. We always agree in court.
Hi, my question is for Dr. David Bogart. I'm a Christian Medicolegal, one of the consultant anaesthetists from Pinderfields. Mind you, I'm a pediatric anaesthetist by trade. I don't know what I'm doing here anyway.
Are you asking me what you're doing here? Because you don't know.
He's a judge.
So the thing is, when I'm on call for maternity also. And when I'm on call, I've been called for those few occasions where everything is always in a rush, in a panic situation. And I've come across situations from my question specifically relates to medical legal documentation of anesthetic charts. And in a rush, what usually tends to happen is I try to oversee the chaos while my junior trainee gets on with the notes. And I find that very, 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 very uncomfortable, because at the end of the case, when I review the notes, what is written, I wouldn't have written it the same way. And I have to start making additions with a different ink, with my handwriting on it. So in your medical legal practice, how frequently have you come across cases where the anaesthetists have been blamed because the notes have not been written to what it should have been written? If, say for example, I had to write it myself, but I don't have the time to write it in real time. And in retrospect, I have to now make up things.
I mean, as I said, record keeping, and Derek will absolutely agree with me, record keeping is key in defending your practice. And you're right. I mean, I encounter exactly the same thing, and I've come across many sets of notes which have been overwritten or which had additions made to them later on. But the important thing is that any note you make later on has to be indicated as a note that was made later on, so as a retrospective note made after the event. And has to be timed and dated as such. And in extremis, where you're desperately trying to save a mother who's having a massive obstetric hemorrhage, there's no time to record any data at all, you've got two options at the end. One is to, well, first of all, is to persuade your bloody trust to buy automated recording equipment that actually prints the bloody chart out instead of having to write it down by hand. The second option is to bring up the trend screens at the end when the patient's gone to ITU and write it all down at that point and note you're doing that. And the third is to actually photograph the trend screens and get them printed out and put them in the notes. And I've seen that used in a patient who died during an elective gynecology case by the consultant who rescued her somewhat too late. And it can make all the difference between criminal and civil litigation as much as anything else.
Hi. Yeah. I'm Dr. Latik. I'm a consultant anaesthetist here in Hull. One question to both of you, actually. More and more we are hearing this term of corporate manslaughter. And it only came very recently in the news as well. So what will be the implications if that happens, if there's a corporate manslaughter? What will be the implications for the rest of the staff of that hospital?
Okay, so I can comment a bit about this because I was involved in the case to which you are referring. But I was sacked by the instructing counsel for the Crown Prosecution Service when I told them that there wasn't going to be a successful case of manslaughter. And indeed there wasn't a successful case of manslaughter. So perhaps it should have kept me on. It's the only case of corporate manslaughter ever brought within the NHS, or indeed within the health system. And it may well be the only case for some time. It was such a disaster, the way the whole thing collapsed. I think it's going to be a very, very long time before the Crown Prosecution Service try to ever do this again. But the upshot, if they had succeeded in the case, was that the chief executive would probably have got a prison sentence. As the chief executive is responsible for delivery of clinical governance to that trust, and would therefore be held responsible if the trust had failed to the point where a patient died, and that's what corporate manslaughter means.
A worrying thing, I mean, I know David apparently sits as a coroner at times. I think the most scary hearings for clinicians are
coroner's courts, absolutely.
Yeah. The coroners have more or less unlimited powers, and they can be as irrational as they want, and they can come out and tell them this as well, David, if you want to go. I say this about coroners. That they, some coroners, of course.
I'm not a coroner anymore.
Yeah, some of them have absolutely, completely unrealistic expectations of what a medical service can deliver. So I read a case the other night where the coroner has given their judgment, and a woman was admitted at 10 o'clock at night to a maternity unit with vomiting at about 34 weeks pregnant. And the coroner couldn't understand why the consultant who was responsible for her care hadn't seen her that night. 10 o'clock, any night. It wasn't on call. Was actually not in the hospital for another 2 days because of other commitments. So, but the coroner couldn't understand why the consultant wasn't told at 10 o'clock at night that his patient had come into hospital.
I don't agree. Coronial services are an absolute lottery, and of all the courts you should fear after the GMC, the coroner's court is the next one. And it's not just that, of course. Patients and their relatives are allowed to ask you, or the relatives are allowed to ask you questions directly in coroner's court, to address you directly. There was a case reported in the Times last week where a relative had to be taken out of court and was arrested by the police after threatening with the medical witness with death. He said, you killed my wife, I'm going to come and get you. And that's, to face that when you're standing in the witness box is quite indescribable.
I think we're going to have to wind up for a second, but I'm going to say two more quick things. It's only 1992 you're talking about decision to delay time.
Decision to delay time,
yes.
A special anaesthetic.
No decision without delay. But 1992, Southmead Hospital, Bristol, we still had a mobile anaesthetic room, and if the obstetrician said section, we take the anaesthetic machine to the room and do a GA in the room. The obstetricians were delighted. I'm not sure how you get away with that. But I want to ask you on a more serious point. How objective do you think you are as medical legal advisors? When you get a case and you're about to open that book, do you think you are naturally tending towards defending your colleagues?
After you do.
Yeah, no, I mean, it's a very fair point, because if you ask lawyers who represented clients, and that's either hospitals or claimants, they would suggest that there were certain experts that they saw as being more favourable to one party than the other. It is very, very difficult to say that you're absolutely impartial one way or the other. The only thing I can say from my own point of view is that actually, sadly, I'm relatively unusual in that I do I do slightly more defendant than claimant cases. Most of the obstetric experts do either claimant or defendant. So I do about 60% defendant, 40% claimant. And I have to confess, I read the notes and I write my opinion, and then I think, crikey, who am I writing this for? And I think that's the only way I can be reasonably secure in giving an opinion which is based upon the evidence of the case, rather than... now, as David will tell you, the problem is I write my initial review, and then I go to a conference with the barrister for whichever side is instructing me, and they're quite clever at twisting things. And suddenly what you've written may not necessarily be what turns out to be in the case. And sometimes, actually, what I've said will not truly be represented in the court pleadings, but the barrister will put to you a specific factual position. It's not the factual position upon which you based your preliminary case review, but if you change the factual position, it changes your interpretation of the case, and that's how they build a case, either for the defendants or for the claimants. Both sides are just as bad at it. So as an expert, I could get a reputation of being favourable to one party or the other, to a large extent dependent upon the skill of the barrister with which I work.
But there's such professional jeopardy facing expert witnesses who seem to be biased in one direction or another now, that actually it's far less common than it used to be. And actually that medical manslaughter trial is quite a good case in point. So you take a look at the anaesthetic evidence in that. I'm not going to mention any names. And you may come to the conclusion that the anaesthetic expert in that was somewhat biased towards one side or another. I couldn't possibly comment. And he could face professional shame as a result of it.
Okay, well, I'd like to thank both our experts.